Good morning, everyone, and thank you very much for inviting me here today. It's an absolute privilege to be with you all. So I just want to talk a little bit about the work we do, but before I do that, I just want to kind of set the scene as to why I think patient safety is so important and why the work that all of us are doing is so important at the moment. I want to start by just taking us back 20 years, and it's 20 years since the London bombings. And over the summer, there was quite a lot of dramas and documentaries on the telly. And I ended up watching this one on Disney Plus, which was about the very tragic shooting of Jean-Charles de Menezes after the bombings. So many of you might remember the tragic bombings that happened in London, and then 2 weeks later there was a failed attempt. And then after that, this very innocent man got shot at Stockwell Station. And what happened is a fascinating, I think, case study that we need to learn from in patient safety. So there was a house that was under surveillance, and during that surveillance, as Jean-Charles de Menezes came out of the house, he wasn't the suspect, but the chap who was surveilling him had gone to the loo. The communication systems were broken and didn't work. There were new protocols in place that hadn't been tested or trained, and there was firearms officers who hadn't used those new protocols before. There was a real context of heightened anxiety and stress, and everyone was under real stress and real pressure from lots of different areas. And then after this very innocent man got shot, there was a whole range of things that happened. Firstly, there was very poor leadership. The leadership tried to cover up what had happened, and there was a real attempt to silence things in the media. There was a lack of duty of candour. No one was kind of able to talk about what had happened and kind of talk about the truth about what had happened. It became very clear there was a lack of cultural competency across the services involved. People were not clear about how to look at, how to understand ethnicity and how to really look at kind of cultural factors. There was a whistleblower. The whistleblower got fired after raising concerns. And importantly, the family couldn't get the answers they wanted. They tried and tried and tried to get the answers that they wanted. And they had to battle, and they ended up battling and asking for a public inquiry. And there was a public inquiry as a result. And the firearms officers got the blame for the situation. Now, I don't know if any of those messages sound familiar to you. 20 years on, we must have changed, mustn't we? That can't be still happening. And yet, if you look at the front pages of many of the papers over the last year, whether it's infected blood, maternity, various other scandals that have happened in the NHS, many of them still have the same themes. Just moving on, you've probably seen this about NHS public satisfaction. We're in a situation where the NHS has the lowest public satisfaction that it's ever had at the moment. Now, there's a whole range of reasons for that, waiting lists and waiting times and urgent emergency care pressures. But I would argue that these scandals and these things that the media kind of talk about every day don't help with public confidence. And we have a job to do to really kind of get public back confident with the NHS again. And I think delivering better patient safety is part of that. I also want to talk about the context we're in terms of the money. So as everyone knows, the NHS is in a really tight position at the moment in terms of money. Financial decisions, operational decisions are driving lots of the overall decision-making in the NHS. And often I find that patient safety is not discussed when those discussions are happening. Often people talk about how they're going to save money by cutting costs, by cutting staff. No one actually talks about how do we improve the financial position by making care safer. And yet we know that the OECD, when they talk about patient safety, the OECD countries, there's an estimation that 13% of all healthcare spending is on safety failure. Now, if you look at the NHS budget for England, that's over £25 billion on safety failure each year. Can you imagine what that would do if we could put that money back into the NHS? There's a report today you may have seen from the NAO about the cost of litigation, which is worth a read, but that's just part of a much bigger picture in terms of excess bed days, medication errors, all of the things, the rework that happens due to safety failure. And actually, the OECD have done some brilliant work around diagnostic error as well, which you may have seen, saying that 17.5% of healthcare spend is on diagnostic error. And so I think we need to be pushing the system to really think about how we put safety much further ahead, further upstream than we are at the moment. What I see in the system is a system that makes business cases, makes decisions, then does a quality impact assessment, then does an equalities impact assessment, often both of which are tick box and do not lead to the changes. So how do we collectively look at nudging the system to put patient safety right at the beginning of that decision making, which I believe would really help the spread and adoption of innovation and really enable things to move forward. So in that context, I just want to give you a description of what we do as an organisation. So we have been set up as an arm's length body of the Department in Health and Social Care, and we've been running now since October 2023. And we investigate anything that relates to patient safety across England, and we undertake about up to 20 investigations a year. And we look at things that have happened in multiple places that cause significant harm. We look at where we can address inequalities and where we can add value through our legislation. And we've got some really interesting legislation. The first thing is we can compel people to get involved in our investigations. We don't like doing that. We don't want to sit in front of people and say, you must talk to us, because we don't think that's actually the approach we want. But sometimes that is helpful for people to understand. We can investigate any part of the healthcare system that there's a patient safety concern, and we can, that includes the independent sector as well. And often our investigations look at the transitions of care between different parts of the system, because that's often where we see safety problems. Importantly, people can talk to us in confidence, and any information that they talk to us in the course of investigation is protected by law. We've got really strong legislation which actually trumps things like whistleblowing and safeguarding legislation, called protected disclosure legislation. And this is important, we think, because actually it's really important for people to be able to speak freely about things that have gone wrong, to feel that they're in a safe space, and that they can really talk about things without being worried about getting into trouble with their organisations or with their managers. We don't name individuals, we don't name trusts we don't name any providers in our investigation reports. It's really about that learning. And then we make recommendations into national bodies about what needs to change. Often things there's a lot in control of what happens at a provider level, but some things need a national solution, and those are the things that we make recommendations about. So that's essentially what we do in a nutshell. We've covered a whole range of different areas over the last year or two, which are shown here. Some of the kind of the things that we all talk about in patient safety around sepsis, never events, those type of things. But some of the kind of things that are emerging and we think are important to talk about, like the risk of fatigue. We've done a lot of work around mental health in patients. So we've covered virtually every area of healthcare, but continue to kind of look at different aspects and see what's happening in those areas. I've got a team of investigators that are rooted in kind of safety science and human factors backgrounds. They're an expert team who come from a whole range of different safety critical industries, from aviation, from nuclear, from legal backgrounds, some clinicians, a real mix. And what they do, as well as looking at the kind of work that's done already and the literature searches and interviews, they go out and observe practice. And this is really important because they go out on site, they see what is actually happening on the ground. And what we find is actually what is actually happening is often very different than what people think is happening. So what the policy says actually when you look and see what people are doing often is quite different. And often then what people talk about is happening can be quite different than what's actually happening as well. And this is really important for us to understand when we're looking at patient safety, because it's all very well having great policies and great things written down, but actually if they're not really translating into what people are doing when they're under pressure, when they can't find the bit of kit they need, when they're short-staffed, that's where the problems sometimes lie. We also have an education programme, and I can see one of our education team in the audience, which is fantastic. And what we're trying to do with our education programme is look at actually how do we improve the quality of the local investigations that take place. We know that often local investigations, that they can sometimes not involve patients and families well. They don't always lead to the change that needs to happen on the ground. And sometimes staff members often feel isolated from those processes. And we've seen in some of our investigations about how these things can be career-ending or career-changing for people working in the system. So do have a look at our website. We've got lots on offer, and our education courses are delivered free of charge to the NHS. I just wanted to move on and just talk about a little bit of learning we've had, particularly from our mental health investigations recently. And what we see in a lot of our investigations is that we're still working in quite a blame culture across the NHS. This is driving quite a culture of fearfulness and defensiveness, which in itself, I think, is a problem for patient safety. And I think we really need to understand this in more detail. And I just pulled up this example of a report that we did, an interim report from our Learning from Deaths work in mental health inpatients. And what we found, so I understand in mental health inpatients, the national guidance says you shouldn't use risk assessment tools in terms of self-harm. And yet when we went out on the ground, what we found was lots of people were using these risk assessment tools. And so I guess the initial thing is, why are those health professionals not keeping up to date with what the national guidance says? That would be the traditional way of looking at this. But when we went and observed practice, we found two things. One was that the IT systems in these units were forcing people to put a risk assessment in before they could actually move on to the next screen. And the second thing that was happening was actually the coroners. If people were ending up in coroners' courts, people were being very much given a hard time if they hadn't used one of these risk stratification tools. So often when we're looking at why things are blaming individuals, often we need to look at the factors as to why individuals are kind of behaving in a certain way and why they're not following things. And that's the bit I think is going to be critical in terms of moving forward, really understanding those barriers to implementation and barriers to doing the right thing. I just also wanted to touch on another piece of work we're doing, which I can't go into detail now, but I'd love to have further conversations with people if they were interested. And this is around recommendations made into the system. I've been leading a piece of work across the system around recommendations made from multiple organisations and looking at working with all of the national organisations in the NHS. And what we found is the system is rather overwhelmed with recommendations. There's hundreds of them. Often they're duplicative, often they're conflicting. They don't often think about inequalities or population health and population needs. They're not costed and often relaying in kind of recommendations into the system that aren't costed. And the kind of overall output of this is often nothing's happening with many of these recommendations. We don't know what's happening with a lot of them. And we're certainly seeing time and time again things that keep happening, same instance despite recommendations. So I'm working with the National Quality Board at the moment, looking at actually how do we improve the quality of recommendations, how do we try and slow down the flow so there's less, more impactful recommendations, and how do we set up a recommendations hub where the key recommendations can be looked at, can be prioritised by the National Quality Board and then tracked and the implementation understood. So that's work underway, and if anyone would like any more information, please let us know. So I'm almost through my slides, but I will just give a couple of examples of the impact that we've had. We're really pleased that on a daily basis we have examples of where we hear the impact of our work. When I talk to the Air Accident Investigation Branch on who we're modelled, they've been set up for 100 years. And their advice to me was, there's no silver bullet. It doesn't happen overnight. These things that you'll see, those incremental improvements over time, over 100 years they have made huge improvements. And I believe in aviation, for example, they haven't had a public inquiry since the 70s because of the impact of the Air Accident Investigation Body. And so I think the answer with what we're doing, it's quite difficult for us to measure impact because sometimes that takes a long time. I think it's something we all struggle with. But nonetheless, we do see some lovely examples. And recently, for example, we've heard from the Aortic Dissection UK charity. We did some work on aortic dissection about 4 or 5 years ago now. And then subsequent to that, worked with the Royal College of Emergency Medicine and the Royal College of Radiologists. And as a result of that work, there's now some data that shows that 315 people every year in England are getting aortic dissection surgery that weren't 5 years ago, which I think is fantastic. And the UK Aortic Dissection charity feel that's very much to the work that we did and the subsequent actions of the colleges. So that's a lovely example of the kind of type of impact that we have. Just to give another one and just to kind of talk through the process, we investigated a very sad case of a 5-year-old who ended up dying from cancer. And she and her parents didn't speak English, and they went into the outpatient appointments. They had a translator in the outpatient appointment. And then they went home, waited for the appointment to come through, got the letter, could read the date on the letter and the time for the MRI scan, but couldn't actually read that they needed to be fasted because they didn't understand it because it wasn't in their native language. And so they ended up going to the MRI scan, being turned away, getting lost for follow-up. 10 weeks later, the child went back in for the scan, by which time the cancer was very advanced. And so, and it's something, we went out and tested, and actually, despite the technology being there for translation of letters and translation of information to patients where needed, it's not switched on in most trusts, and it's not being used. And so we were delighted when we saw we made a recommendation to NHS England. Bola Oluwabi, when she was in the position of Director for Inequalities at NHS England, brought out this improvement framework for community language translation and interpreting services, which will then feed through into the system and address that issue. So that's the kind of flow of how things work and how things can make such a big difference. We're always keen to hear about areas that need investigation. So if you have concerns that you're seeing, that you think are national problems, please feed them through to us. We want to hear from you. We want to get as much intelligence from the system as possible. And then I think I just wanted to talk about what's next for us. You may have seen the Penny Dash review about the landscape of patient safety. The plan is for HSSIB to move into the Care Quality Commission. That will need primary legislation to move us, so it's likely to be in the next kind of 18 months. It won't happen overnight. It's probably going to be at least 18 months before that happens. We're starting to work with the Care Quality Commission to really think about how do we maximise that opportunity of bringing those two organisations together, and how do we really kind of continue with the important independent investigatory function that we have, but work kind of collaboratively with the rest of the patient safety landscape and the quality landscape to make sure that we're all kind of driving as much improvement as possible. And finally, I would love, we've already got some really good relationships with patient safety research collaboratives and NIHR, and I would love to continue those and build on those collaborations. If there's areas you think we can support with the work that we've done, we would love to have a discussion. I think we generate a lot of research questions in our work, and I think that's one area that we would love to build stronger kind of relationships with. We want to hear about the work that you're doing to inform our work, and I think also the work you're doing will raise those kind of areas, as I said, that we should be investigating. So please do get in touch with us. Sadly, I can't stay for the rest of the day, but I'm very happy for you to share my email address, so do email me if you want to have any further conversations. So that's all I was going to say. Very welcome to have any questions, and it's lovely to see you all. Thank you.